Good afternoon. My name is Rana Higgins. I'm a minimally invasive and bariatric surgery fellow at the Medical College of Wisconsin. Dr. John Gould is a consultant for Thorax Medical, but otherwise the remaining authors have nothing to disclose. Failed fundoplication occurs in about 5 to 40% of patients. There's a higher rate of recurrence with increased diaphragmatic stressors, such as obesity and larger hiatal defects. Indications for reoperation include recurrent reflux and dysphagia. Around 75% of failed fundoplications are type 1A, where both the GE junction and the wrap have herniated above the diaphragm. In an attempt to try to decrease the recurrence of type 1A failed fundoplications, hiatal mesh has been used in an attempt to minimize diaphragmatic failure. However, with the use of synthetic mesh, there has been concern about dysphagia and erosions. So as a result, biologic mesh has been increasingly used as a reinforcement in hiatal hernia repair. Olschlager et al. Published a multi-center prospective randomized trial of 108 patients who were randomized to either primary repair or primary repair with biologic mesh. Their short-term outcomes at 6 months demonstrated a decreased hernia recurrence in mesh patients than those without mesh, and all patients had a significant reduction in symptoms. Their follow-up long-term outcomes at a median of around 5 years demonstrated no difference in hernia recurrence, whether the patients had mesh at the hiatus or not. And all patients had a significant reduction in symptoms with no mesh-related complications. Now, revisional anti-reflux surgery itself has quite a significantly high morbidity. There was a systematic review published of 4,500 operations that demonstrated around a 21% rate of intraoperative complications and a 15% rate of postoperative complications in patients undergoing revisional anti-reflux surgery. Now, when taking into account mesh at the hiatus, there have been some published cohort studies demonstrating an increased risk of major esophageal and gastric resection in patients undergoing revisional anti-reflux operations who have prior hiatal mesh. Parker published a study of 78 patients and demonstrated that hiatal mesh patients had around a 7-fold increased risk of major resection. And Nandapati's group published a study of 27 patients and demonstrated that just under a third of them required distal or subtotal esophagectomy. So the purpose of our study was to determine the impact of pre-existing mesh at the hiatus on the morbidity of revisional surgery in patients undergoing who have a failed fundoplication. So we performed a retrospective review of our institutional Foregut database. We identified 104 patients between the years of 2011 and 2015 who had revisional anti-reflux surgery. We then, amongst these 104 patients, identified 14 of those patients who had previous mesh at the hiatus. We then matched them 1 to 2 with control patients in our revisional foregut surgery database by number of previous revision attempts, as well as the type of operation performed. So as you can see, we had 104 revisional anti-reflux patients within our foregut database. 14 of them had previous hiatal mesh prior to our operation, and 90 did not. These groups were then matched 1 to 2 in a randomized fashion, both based on operation type, whether it was a Nissen or Toupet fundoplication or a gastric bypass, and number of previous operative attempts, 1, 2, or 3. So here's a table of the demographics of our patients with previous mesh at the hiatus. Of the 14 patients, 4 had a Roux-en-Y gastric bypass that we performed as their revisional surgery, and therefore we matched this with 8 control patients for those who did not have mesh. Amongst the fundoplication group, there were a total of 10 combining Nissen and Toupet fundoplications. One thing to note is within these 4 patients who had 2 previous foregut surgeries and we performed a Nissen fundoplication, we were only able to come up with 7 controls as opposed to 8 controls, so meaning there were only 7 patients in the no mesh group that had 2 previous foregut surgeries and we performed a fundoplication on, which explains why we only have 19 control patients as opposed to the 20. So whether we performed a fundoplication or a gastric bypass, we followed an algorithm. One question we would ask is whether the patient was morbidly obese. If they were, then we would consider performing a revisional gastric bypass. If not, then we would evaluate whether they have post-surgical gastroparesis. If yes, then we considered a revisional gastric bypass. If not, if they had more than one prior fundoplication, we would consider a revisional gastric bypass, and if not, then we would perform a reoperative fundoplication. So these are our results. In the prior mesh group, there were 14 patients, and in the without mesh group, there were 27. There was no difference in the 30-day readmission rate of 28% versus 26%. The 30-day morbidity did not demonstrate any statistical significance at 29% versus 37%. There was one episode of intraoperative perforation in the prior mesh group. There were no perforations in the without mesh group, but again, this was not statistically significant. The mean operative time was also not significant between the two groups, neither was mean length of stay. There were no mortalities and no conversions to open in this cohort. So in regard to the 30-day morbidity, there were 4 patients with prior mesh who had morbidities. One was a reoperation for port site pain. Another was a readmission for nausea and dehydration and pneumonia. Within the no prior mesh group, there were 10 patients who had a morbidity, including a reoperation for drainage of a subphrenic abscess, readmission for nausea and dehydration, respiratory complications such as pneumonia, empyema, pulmonary embolism, and ARDS, surgical site and urinary tract infections, and 1 patient who had a colonic pseudoobstruction. We also performed a sub-analysis of patients with synthetic and biologic mesh. There were 9 patients with synthetic and 5 with biologic. We found no difference in the 30-day morbidity or the mean operative time when comparing patients with synthetic and biologic mesh. So in conclusion, we identified no increased morbidity, operative time, or length of stay in revisional foregut surgery patients who had prior hiatal mesh. We've also found no difference in morbidity or operative time in patients with synthetic versus biologic mesh. Now, of course, this does not address the controversy regarding the impact of mesh on recurrence. It simply discusses perioperative outcomes in this patient population. So we conclude that mesh at the hiatus does not increase the morbidity of reoperative anti-reflux surgery. Thank you.